Welcome back to the Gillett Health podcast. This is going to be another installment in our Just the Basics series. Today we're going to be talking about testosterone pills. And I should have introduced myself first, but my name is James O'Hara, and I'm a nurse practitioner. And with that, let's go to our obligatory meme, as we have to in these Just the Basics series. So here we have a cartoon of two physicians discussing testosterone pills. Testosterone pills have a long-running stigma of being liver toxic or bad for the liver. So here we have one physician asking the other, "What do you think about lymphatically absorbed oral testosterone?" And the other physician says, "All testosterone pills will ruin your liver." So as the podcast progresses, you will understand what this means. And in other news, NASA has made an object that travels over 400,000 miles per hour. It's called the Parker Solar Probe. It also got very hot close to the sun. But the reason I mention the speed is because 400,000 miles per hour is about as quick as you should leave your physician's office if they tell you that all testosterone pills will ruin your liver. And with that, let's talk about testosterone pills. So the first subject here is sort of what is the average physician or PA or nurse practitioner doing in practice with testosterone pills? They're not incredibly widely used. Still, creams and injections are much more common, much more popular, but there is more awareness of these testosterone pills as options, and there's some differences we'll talk through. So what most physicians are doing is using the on-label dosing. It's the sort of, you have low, medium, and high doses because everybody is going to absorb and metabolize things a little bit differently. So they're following the label. They're starting with the middle dose. So for this particular product, 237 milligrams. The detail here is that it has to be taken with food, specifically fat, so that the medication can be properly absorbed lymphatically. You're going to lose quite a bit of the peak level if you don't have a substantial amount of fat with that meal. In the range that they're targeting, and this is not an average range, but this is what they're looking at for a peak about 6 hours after the medication is taken, is somewhere above 425 nanogram per deciliter to 970 nanogram per deciliter. So a pretty broad range, but it is sort of targeting above and beyond just normalizing testosterone at, say, 301 nanogram per deciliter. So today's myth is that testosterone pills will destroy your liver. And today's truth is that newer formulations are mostly lymphatically absorbed and actually decrease liver fat significantly. So there's actually been a handful of studies here, 2 or 3 that I can think of, where this testosterone form being used in hypogonadal men, so that means men with low testosterone, typically below 300 or 250 nanogram per deciliter, and fatty liver disease, or in some studies, diabetes, which those individuals tend to have some fatty liver disease as well, actually reduces the liver fat, and the reduction in liver fat is not proportional to the change in their body weight, which is interesting because that points to a drug effect as opposed to a body weight effect. Fatty liver disease is very prevalent, but it is one of the sort of chronic conditions that is very easy to resolve with proper weight loss. So easy, I suppose, is a relative term, but that's really the only change that's needed in order to resolve the fatty liver disease. And if you're looking at testosterone, these oral forms are lymphatically absorbed, so they bypass the first pass effect, which is why they're not liver toxic. The first pass effect just refers to how drugs are processed by the liver. Most medications, when you take them, portal circulation and so forth, beyond the scope of our Just the Basics podcast here. But basically, the take home here is you can get about a 40% reduction in liver fat in 4 months, at least in this one study, which I couldn't access the full text of, but it appears that this has also been replicated, so it doesn't seem to be a sort of one-off outlier study. So sort of counter to this idea of testosterone pills always being bad for the liver. And that's what we're talking about here. So when it comes to explaining the science, how does this work? It is a little bit complicated. It's more complicated than just your testosterone cream that absorbs through the skin, or your testosterone injection that's absorbed from the subcutaneous tissue or the intramuscular tissue. The detail, like I mentioned, has to be taken with food. It is absorbed in the GI tract, and then these chylomicrons actually transport it to the lymphatic system, and then it is absorbed into the lymphatic system, and then it is released into circulation, and it goes everywhere in the body. So that's the simple version. These chylomicrons may or may not be the reason that you get a proportionally larger effect in the liver as far as androgenicity. Things like lowering the amount of liver fat or lowering sex hormone binding globulin, which we've talked quite a bit about on this podcast. Our regular listeners will know about sex hormone binding globulin, but it's a protein that essentially regulates how testosterone and DHT and estrogen are delivered to tissue and metabolized in the body. Kind of think of it as a reservoir and a transport protein. So you do see a drop in the SHBG whenever testosterone decanoate, testosterone pills like this are taken. So that's something to be mindful of in this conversation about benefits and risks. And then how does the drug look in terms of pharmacokinetics? So this is something that we think is important to talk about, something to look at. It really helps patients when they can visually see what this drug level is going to be like, what the expected outcomes are. And this is sort of your average dosing here. So this is from the package insert for a oral testosterone preparation. And you can see that there is a peak for the first dose actually quite soon. So about 2 hours after that dose, you're going to see a peak. About 4 hours after the second dose, it looks like you get a peak. So you're sort of looking at like 3-ish hours to see what that peak level is, depending on which dose. But you're measuring at 6 hours post. 5 to 6 hours, I believe, is what the label will say in terms of kind of getting an idea of not necessarily the true absolute peak, but where is someone spending a substantial amount of time that the drug is in their system at? So, are they only getting up to 300? Or are they getting up too high? Are they getting up to 1,500? As people are going to absorb things differently. Basically, you want to have at least 30 grams of fat. That's how this was done. I've heard that some people are saying on podcasts that it doesn't need to be taken with fat. And I suppose you would still get some absorption, but you are certainly not getting the most out of the medication that way. And I suppose the most important way to take it would be consistent with your dosing. So if you take it with 0 grams of fat, probably going to end up on a higher dose because you're not absorbing it as well. And then one day, if you do have it with a fattier breakfast, say some eggs, something like that, you're going to end up absorbing substantially more. So that's something to keep in mind. But about 30 grams looks like the sweet spot. If you get at least 15, you at least get 75% of the absorption or total exposure, the area under the curve, as we would call it. So that's not terrible, but 30 is sort of going to be what I think is more predictable. One of the other unique things is the interaction with testosterone conversion to DHT, the 5-alpha reductase enzyme, with this form of testosterone. And as we've talked about in our other episodes of Just the Basics, there is differences in things like there are differences in things like your testosterone injections, your testosterone creams, and testosterone pills in relation to how much DHT they convert to, or how much DHT is able to be blocked, how much of that conversion is able to be blocked, as is the case here. So if we're looking at, this is a study where it actually had some pretty high peak levels of testosterone. So, these aren't necessarily reflective of what you might see in practice, but for the study purposes, this is the doses that were used and the serum levels that were achieved. So the Cmax just means the maximum concentration of testosterone, maximum concentration of DHT. So you have a placebo, one that took a 0.5 milligram of finasteride. So finasteride is a medication that is commonly used for hair loss and also prostate enlargement in men. And a lot of people are on this proactively for hair loss. A lot of people will go on finasteride or dutasteride when they start TRT if they want to lower their DHT exposure. But what you can see here that's quite interesting is that you're not getting too much of a reduction in the DHT by taking this with the finasteride. So there's something about this lymphatically absorbed testosterone that is preventing the finasteride from accessing all of the 5-alpha reductase enzymes. So I truly don't know if this happens in the lymphatic system, if this is happening because you get a higher seemingly androgenic impact in the liver. We talked about SHBG dropping is typically a sign of androgen impact. Other things can impact that too, but for purpose of this podcast, we know that this testosterone and decanoate, these testosterone pills, will cause a drop in SHBG. So it still does decrease the DHT a little bit, but it's not decreasing at 70% like you might see with an injection or like dutasteride, which could lower things by 90%. I don't think you would see that effect there either. If we're going down and looking at the sort of area under the curve, total exposure, so this is like the average testosterone and DHT levels these people are exposed to over 12 hours, you're still getting exposed to over 100 nanogram per deciliter, which is much higher, I think, than any natural DHT level that I've seen. And the ratio is also much higher. So you typically look at DHT converting at about a 5 to 10% conversion rate of your testosterone. So testosterone of 1,000, you might see a DHT of 50 to 100. That's sort of the ballpark and the range that you might see depending on how high someone's testosterone is, how predisposed they are to conversion to DHT, other factors like that that can impact it. And here you're seeing this ratio sort of skewed towards the top. So even exceeding, like at the peak levels, it exceeds 10%. So if you're looking at about a 250 nanogram per deciliter versus a 1750 total testosterone, that's well over 10%. So you're sort of skewing things away from the natural conversion ratio. And I really think that's one of the big differences in this compared to an injection. The injection is going to have a pretty steady state conversion. It's really not going to be significantly different than your natural testosterone production and conversion, where this is giving you more DHT in that spectrum of testosterone to DHT. And that can be important if we're talking about like testosterone converting to DHT leading to hair loss or prostate issues. There's no outcome studies, and people who have looked at and listened to our podcast know that I'm a stickler for outcomes. I like to see, okay, but what happens in the real world? We can talk about physiology all day long, how these things work in the body, but would it actually cause men to have more prostate issues like prostate cancers or issues with urination, issues with hair loss? I would say presumably so for the latter, meaning the hair loss. But the others I don't believe have been studied and shown to cause issues. And this is something you would really have to measure over a long period of time. So if these become more widely adopted, meaning these testosterone pills, then we might get some of that data, which I think could be interesting. Moving on to, what do I do in clinical practice? I will tend to not use this as a standalone, not because it's necessarily a bad strategy or a bad drug or there's anything wrong with it. Patients just don't tend to feel the same benefits that they do with injections. I haven't found anybody that has really liked it as a testosterone replacement, at least as far as the male patient population. And I also, in practice, have a lot of people that are interested in preserving their hair, not having hair loss. So the DHT not being completely blocked by finasteride or dutasteride as far as that conversion process. It's another thing that would perhaps sway some of my patients away from considering the oral, but It could be used with a lower dose injectable testosterone as sort of a base. So you may have someone on 50 or 60 milligrams of testosterone per week in an injection, and you may add one or two of these pills taken only in the morning to sort of simulate or emulate your natural morning spike. So that would be for someone who perhaps is a bit overstimulated or feels like it's too much for them to have a testosterone in the upper half of the range purely from injections, because with injections, you're going to wake up and go to bed basically the same testosterone level. So whether that's 600 or 900, you're sort of there most of the time, at least on a more frequent injection protocol like we would tend to prescribe. Another potential advantage of the oral testosterones is that you have it faster into the system and faster out of the system. So the clinical effects, as far as what you feel from the testosterone, should happen more quickly because your serum levels, basically they're up as soon as you start taking them. You don't have to wait a month or 6 weeks for your levels to build up like you would with an injection. Potentially less pituitary suppression. This is sort of the pattern you see with longer and lasting forms like a cypionate or an anthate injection, leading to really substantial suppression of LH and FSH, which are hormones produced by the pituitary used for your natural testosterone production and also in fertility. So that's why testosterone can interfere with fertility. But as we mentioned in previous Just the Basics episodes, that's not a permanent effect. It's something where you should have a baseline fertility assessment if fertility plans are in your future, and have a conversation about, what would we do to come off of testosterone or address fertility. Those are things you can discuss with your provider. It does have to be taken with food. Easier to recover your natural production with this form instead of waiting a month for the testosterone to completely wash out of your system like you might have with an injection. Basically, the day after you have taken this, your natural production will sort of start to come back online. So you're looking at a much quicker recovery of your natural production back to your baseline state, presuming that it's, a relatively short amount of time you've been on it. Sort of if you're, thinking about a trial of testosterone, which is how I talk to my patients about it. You're not, because you do one injection or take a couple of testosterone pills doesn't mean you're tethered to it for life, but it's sort of a trial to see how you feel, what your blood work looks like, how you respond to it overall. It may be better for libido, another advantage potentially with the oral testosterone, because it does increase that DHT more. So it's a little bit more androgenic, and potentially that fluctuation in testosterone levels as opposed to a steady state that your body and perhaps dopamine system adapts to might also be an advantage in terms of libido. So I think some people would benefit from that if that's specifically what they're looking for in terms of their testosterone replacement therapy. So you could put that in the pro column. And it can be a pro or it could be a con, depending on what your goals are for prostate health, hair loss, and total androgen exposure. Some people are on their testosterone creams and they really like the high DHT. They feel good on that. Other people feel overstimulated or perhaps shortens their fuse a little bit in terms of their temper. This is interesting because if you're someone, let's say like myself, taking dutasteride and you wanted to spike your DHT for some reason, you could do that by taking this testosterone pill. The orally lymphatically absorbed testosterone will sort of get around the 5-alpha reductase inhibitor you're taking, and you could spike your DHT. So if you're someone who wants to at least have some DHT binding the androgen receptor from time to time for a more natural approach, this is a way you could sort of get around that without having to go off of your finasteride or dutasteride and get that DHT to bind. But it's also the downside, like I mentioned. There's not, as far as we know yet, an effective way to block that conversion with this form. So the question that a lot of people ask is, what do you think about testosterone pills, or what do you think about oral testosterone? Well, I certainly don't think that this form of oral testosterone or this form of testosterone pills are liver toxic or going to fry your liver, damage your liver. but I don't think they're the best option for everyone. Some people may use these while they're traveling if they don't want to transport injection supplies. Some people may use these in my practice as part of a hybrid protocol where they have a little bit of an injection. They spike their testosterone in the morning with these. But like I said, I haven't found people that love being on just the testosterone pills and timing it with their breakfast and lunch because life is busy. You'll miss doses. Those things can happen. But for some people, it could be a very good fit. So if you are considering these, probably go to a clinic that doesn't prescribe just only oral testosterone, but go to a clinic that can prescribe and talk about the benefits and downsides of each form of testosterone. And if you're interested in some of those, check out our previous episodes of just the basics where we talk about injections and creams, what you should do before you think about taking testosterone, and learn a little bit about how it works. Thank you so much for listening. Thank you for your time. May God bless you with health and happiness.